All right, so this discussion, we're going to look at the post-operative care. This is a nursing care that you give to a patient after undergoing a particular type of operation. So this is given to patients coming from the theater. Patient could have been taken to the theater under emergency conditions, or it's an operation that was planned. This can be planned for a month, even for a year, or even days. So as we care for this patient, we must have some aims. What do we want to achieve? What do we want to do for this particular patient who has just been brought to us after an operation? So post-operative aims focus on monitoring the patient's condition. Here you're trying to see if the patient is improving. You want to see how they respond to that operation that was done on them. You're also trying to prevent, various complications from happening, or you want to detect those complications way early so that you can come up with interventions to limit such complications. So we focus on post-operative observations or monitoring, if you like. You also focus on pain management. Of course, surgery involves intentionally wounding the patient. So you're causing wounds to the patient, of course, with the aim of solving a surgical problem. It could be a tumor, it could be some internal organ damage, or it could be infection. Various reasons for operations. Another issue that you must be critical with, especially when managing the patient post-operatively, is infection prevention. This is one of the commonest complications that patients coming from theater have. Those wounds expose the internal environment of the human body to the external. And we know that the external environment is full of microorganisms, viruses, fungus, bacteria, just to mention a few. So want to prevent such kind of infections that may actually alter or delay the wound from healing, or actually bring about various complications that may actually lead to mortality or death of the patient. Example given is sepsis, where infection and toxin spreads to the circulatory system, overwhelming the body, causing septic shock and eventual death of the patient. In addition to that, we want to ensure that this patient who has left the operation room or the theater is receiving adequate nutritional intake to promote recovery. Now, post-operative care is divided mainly into two parts. You are looking at immediate care that you are giving to the patient. This is care given first 24 to 48 hours of an operation. First day, second day after an operation. What are the issues that we are looking at? Then we have subsequent care. This is care given to the patient now in the following days, day 3 going up. And this can last for a week, months, or even a year. That is subsequent care, right? Now, we have this abbreviation that we use to manage this patient called a prophenema. I'm sure most of you are familiar to this terminology. So we're talking about aims, and we've just done that. Then as you are collecting the patient, make sure that you are also paying attention to any emergencies that may arise. So as we go to collect the patient from the theater, we must be ready to respond to any emergency or complication that the patient may present with. All right, patient may vomit because of anesthetic drugs that are given to put them in a state of sleep so that operations are done painless. Okay. So we must be able to respond to such complications. Now, what is important here is that we have to receive the patient. So we have to collect the patient from the theater, of course, having in mind what our aims are, those aims there. Okay, and we're saying when collecting the patient, we must be able to respond to emergencies. In addition to that, we want to assess the patient's condition and get a handover from theater nurses. Okay, so we're going to ensure that we do collect vital signs. So vital signs are essential as we collect the patient from theater. In addition to that, what else are we looking at? So assess the surgical site. Of course, the theater nurses will give you handover and give you the latest vital signs that was collected on the patient. In addition to that, you must get your own vital signs, check the patient, ensure you know what vital signs are, and then check the surgical site. Of course, you're not going to remove the dressing, but inspect, observe, and see if at all there's any active bleeding. Is blood oozing? Is the dressing getting more wet with blood? Patency, we're looking at, is this patient having any tubes? Depending on the operation that was done, especially operations done to the viscera, internal organs, chest, abdomen, pelvis, such procedures or surgery, you may find a patient with drainage tubes because those are hollow spaces and you see that blood and other products, plasma may begin to accumulate in those cavities. To prevent that, tubes are left in situ so that such is drained to prevent infection and other complications. So ensure that all those drainages are patent. They are draining what is supposed to drain. Mainly you see blood in the first 24 hours, then later on the color will keep on changing and the amount will change. Patterns of intravenous, fluids, we're talking about patterns of intravenous, tubes. You're looking at cannulas. These are used for administration of drugs, administration of various fluids, dextrose, normal saline, or Ringer's lactate. Okay. In the process of moving the patient from the theater to the collecting point, you might find that some of these are occluded. They might be occluded with blood, or they are just tied on themselves, or the patient is lying on the tube. So make sure that all those are up and running and they are patent. You have to check for circulation. This one you can do a quick, peripheral, capillary refill. You pinch the nail bed and see if it is filling up quickly with blood. So if you pinch, it turns whitish, the nail bed, then you let go, blood flows back to that area, causing the nail to appear pinkish. You want to ensure that tissues in the periphery, fingers, legs, hands, arms, and so on, are receiving adequate amount of blood, enough for tissues to survive. Sensation, pain status, check also if the patient is vomiting. Then after, you are ready to take this patient back to the wards. Okay, this is just about general anesthesia and some of the drugs given to the patient. So anesthesia mainly helps to perform surgical operations without the patient feeling pain there and then. Of course, these drugs at some point will wear off and pain will be felt by the patient. Depending on the size of the operation, you see that patient will experience pain on different levels. The major the operation, you expect severe pain in such, cases. Other drugs that can be given to the patient are muscle relaxants, analgesics, antiemetics, and antibiotics. So these are drugs, and you know that drugs also have side effects. Therefore, you must be able to monitor those side effects, what you call pharmacovigilance. Patient is in your care. We're looking now at the airway. All right. Is the patient able to perform gaseous exchange? Is air reaching the lungs, where now blood becomes perfused with adequate amount of oxygen? So there are various instances in which the airway can be blocked. Here we're talking about the respiratory tract. So it could be the position of the head in relation to the neck. If the patient's head is flexed where the chin is touching the chest, in that instance, you find that the airway is blocked. Or it could be the patient has aspirated a foreign body, or a patient has aspirated their own gastric contents. This can happen if the patient reacts to anesthesia, or the patient was not starved prior to an operation, or adequate emptying of the stomach was not done prior to the operation. So such are issues that can cause obstruction, or drugs that cause bronchial constriction. Such may lead to airway obstruction. So make sure that the head is extended. This patient is still unconscious, head is extended. Unless they are conscious, then they can just be in any position where they feel comfortable. But if they're unconscious at this stage, neck extended and bent to one side of the body. So here we're saying the head tilted one side and extended. Patient can be in supine position, lying on their back. Okay. In an instance that the tissues are not receiving adequate amount of oxygen, then we can administer O2. Breathing. You have to monitor the rate. Of course, in adults, it's somewhere 15, 16, 18. Normal breath rate, depth, and rhythm of breathing. These are vital functions. The human body should be able to respire. If there's any interference there, we'll see that the patient becomes asphyxiated, low amount of oxygen in blood, low oxygen in the brain cells begin to die, and that can cause death. Now, if you observe the chest and the abdomen, there's what we call seesaw movement. Now, seesaw movement, this is where chest rises, before it fully rises, abdomen rises, chest falls. So seesaw is that motion. You know, there's one kid on the other side, another kid on the other, and they're interchanging in rising and falling. So if you see that happening, especially in an adult, where abdomen and chest are rising and falling simultaneously, then there's a problem somewhere. The diaphragm motion is affected. Okay. So we call that as seesaw movement. That is a significant sign to show that there's some distress, there's some problem somewhere in the respiratory system, where now muscles of assistive muscles, or what we call accessory muscles of respiration, are involved under normal circumstances. When you're breathing at rest, it's only the diaphragm that is essential for air to go in and out of the lungs. Diaphragm will rise and fall, rise and fall. And that causes changes in pressure in the chest, what we call intrathoracic pressure. The intrathoracic pressure drops during inhalation. Intrathoracic pressure increases during exhalation in response to rising and falling of the diaphragm. When you see seesaw motion, that mechanism is affected and the patient requires the emergency intervention. Next is circulation. This is still vital sign. Blood pressure, pulse. Such parameters are essential because they enable human being to survive. Pulse, blood pressure. This mechanism, the pressure of blood against the blood vessels, the rhythm of the heart, sending blood to peripheral organs, that's pulse. Then blood pressure, the pressure exerted by blood against the blood vessels. This is essential because we need molecules which are macro and micro found in blood to reach tissues. And this pressure, what we call blood pressure, enables that movement. Okay. For the brain to receive the nutrients that they need, the blood pressure should be within the normal ranges, what you call homeostasis. That can be thrown out due to drugs. Maybe the patient has been bleeding for too long, or they bled a lot during the operation. Or this drug that was given, what you call anesthesia, the patient is reacting to that. It's suppressing the various factors that control blood pressure, mainly central nervous system. So those are observations. The airway, breathing, circulation. Now, in that environment that you are going to admit the patient after collecting them from the theater, what do we expect? Number one, it must be an environment that is easy for you to monitor the patient. You are monitoring vital signs and other issues. Pain, is the patient vomiting, is the site where the operation was done having any active bleeding. So it must be easy to observe. It must be near where someone responsible to look after the patient should be. So usually we say it must be near the nurse's emergency bay. The room must be kept quiet to avoid disturbances. People are just recovering from operations. Others have already recovered from the anesthesia. They are conscious. They are in pain. And the next thing they don't want is noise. It must be clean to prevent an infection. The environment must be comfortable. At least we don't have to add to the pain. So the beds should be made adequately and patients should be able to have a comfortable rest. So all these must be made sure by us, the nurses. So you have taken care of the patient. It's easy to monitor. The environment is noise-free, it's clean. It's also easy to see. The lighting is adequate. What else? Now we need equipment. Equipment that can enable us to respond to any emergency that can come about. This emergency can happen whether the patient is gained conscious or before. So such equipment like our suction machines, in case of a patient, sometimes they may have a heart attack, a patient may aspirate gastric contents and so on. We need to be able to clear the airway. We want to monitor oxygen saturation, at least in the levels of 90% saturation and above, much better for tissues to survive. So a pulse oximeter is connected to the patient, either the thumb or the toe, to monitor the amount of oxygen in tissues. Then we need an oxygen source. This can be a cylinder or a concentrator, what you call an oxygen machine, which can be given now via a mask or a nasal catheter, whichever is available in the hospital. You need a vital signs tray, intravenous, pour. This is what you call the drip stand for hanging fluids, medication, blood, for blood transfusion, and so on. Because such fluids are given against gravity. You just regulate the pump and then gravity will do its work, and that fluid or blood will be entering the patient's veins for rehydration or replacement of blood and their products, such as plasma, blood cells, etc. We must be able to monitor cardiac hemodynamics. So depending on the facility that you're in, we may find these monitors available. ECG, we have to monitor the heart response to that. Bleeding occurs during surgery because you're cutting flesh, blood vessels are severed, and that can affect various hemodynamic parameters. Blood pressure, heart rate, all those will be affected. Defibrillators must be nearby in cases of cardiac arrest to stimulate the heart once more. Ultrasound may be not so useful, but if available, why not? Okay. And then we should also have an emergency tray with all emergency drugs readily available. So that's the environment. Roughly, that's the ideal environment that we expect patients post-operatively to be nursed in. Clean, noise-free, infection-free, well lit for easy observation. So the environment should be clean, should be comfortable. And of course, us as nurses, we must offer that caring that the patient needs. This patient, we look at their position. How do we keep them in our post-operative beds? So before they recover, a patient must be put in recovery position. So that is supine position with head tilted to one side for easy drainage of secretion. Now, this head we're saying tilted one side, but it must be extended. So neck extension is head facing up so that there is easy flow of air to reach the lungs. If a patient recovers, positioning now will depend on the site of the wound and maybe the underlying condition. If the patient wants to be in a semi-sitting position, well and good. If the operation they underwent can support that. but we don't want patients lying on the wound. Must be free for quick recovery. What else are we looking at? This patient maybe has gained conscious now or not. Either way, this environment must be kept quiet. Movement or access must be restricted. Not everyone should be able to pass through the surgical ward. It all should only be authorized individuals, members of the healthcare team. Okay, and that's why nurses are very good at this when it comes to advising what we call bedsiders or caregivers. That it's time for them to leave so that you can work freely and care for these patients who are coming from the theater. Now, apart from that, we must make sure that anything that is hazardous to the patient is removed in that environment. I forgot this. I beg your pardon. You must remove any hazardous, equipment or objects that can cause injury in that space. It could be sharp instruments. It could be sources of electricity that are left unattended to. Such can cause accidents, and we don't want that. So for rest, you have to control in cases of clinics or hospitals where there are TVs and so on, volume, we must be mindful of that, and so on. Observations. This one we can't be overemphasized. We start with vital signs. Vital signs followed by physical observations. So you are monitoring the patient. If there are any monitors within that ward, ECG, pulse oximeter, you check through and make sure that the readings are within the normal ranges or they are improving towards the normal ranges. Okay, so as a patient recovers, some patients may vomit in response to the anesthesia that was given. Next, we are observing for bleeding from the incision site or the surgery site, if you like. Is the patient bleeding? We did this assessment when we were collecting the patient, but that continues even when the patient is in our wards. Remember, there's what we call reactive hemorrhage. This is hemorrhage that can occur in the first 24 hours of an operation. Sometimes sutures may, rupture or come off. Blood clots may dislodge and cause bleeding to occur again. Patient may lose a lot of blood, and actually death may arise if we're not so meticulous with our observations. Observe for pallor. This is sign of reduced blood flow and oxygen levels in tissues. Cyanosis, bluish discoloration in the mucous membranes and peripheral tissues. You are doing this as a physical examination. You're observing the patient. And then observe the amount of drainage and color from the wound. That is if the patient has drainage tubes, like we mentioned. This is operations to do with abdominal cavities like the thorax or the chest, abdomen, and pelvis. So you're going to monitor the amount. And then that will be added up for the 24 hours and then evaluate how much the patient is losing in a day. The color. So in the initial stage, the color will be, of course, bright red. That is blood. Then with time, color will keep on, changing until maybe just plasma or clear fluid comes out of it as the patient heals. Then level of consciousness. This is important, especially that the patient has been exposed to general anesthesia. You want to see that the patient is recovering their consciousness. So usually we look at, is the patient oriented to the time, place, and persons? What's your name? Where are you? And what happened to you? The patient can mention, I was operated on, and that patient is fully conscious and they're aware of the environment that they are in. Another factor that we are doing while caring for the patient post-operatively is nutrition. This came out even in the AIMS. feeding continues. Now, feeding is part of our vital, it's part of survival, except that we don't see the effects immediately. For example, breathing is essential, is vital for life. Same as feeding. But it may take time for us to see that there's some problem with feeding. If, for example, you starve yourself, you may not die in the first 24 hours. The body can survive, but food is essential and vital for life, because whatever energy the body cells need, body tissues, organs, and systems depends on the energy that can be extracted from the diet that we take in. Now, this diet is essential not just for energy, but also for tissue repair. Okay, tissues mainly are built by a special macromolecule called protein. So that is essential for wound healing. Vitamins are essential for immunity and protect against infection. The body has its own mechanism of responding to infection. So antibodies are produced, cells are sent to attack such kind of foreign microorganisms. Now, to produce adequate amount of antibodies, we need adequate nutrition. And that's why we must look that into, is a patient receiving what they need or what is prescribed for their particular condition? We must be able to advise a patient, even when they're discharged, which type of foods will give them a particular macromolecule and its function. Energy, what type of foods? Protein, vitamins, where do we get such from the food that we eat every day? I'll not go into that. So make sure that patient is fed one way or the other. Patient is unconscious, how do you provide nutrition to them? Patient has gained conscious, how do you now initiate feeding and progress it to the point where they go back to their usual or previous eating? So usually we start with liquids, then we go to semi-solids, then we go to solids. Water, plain water, they take a sip. You can go to semi-solids, these thicker energy-giving drinks. Then we go now finally to solids. So semi-solid, we're talking about, milkshakes, porridge, mashed things, and so on. Blended, fruits, what you call milkshakes, such kind of things. Wound care. This is essential post-operatively. Previously, the patient didn't have a wound, or maybe if it was an accident, they may have wounds, but now they've acquired wounds from an operation. We must clean them. So wound healing is dependent on various factors. Now, there are factors that promote wound healing. There are also factors that delay wound healing. So in our care, we must look at both sides. We must be limiting factors that delay wound healing while promoting factors that promote wound healing. Is the wound clean? Is the wound dry? Okay. Those are factors promoting wound healing. Is the wound receiving adequate amount of blood, so that all those macromolecules needed for tissue repair are available? Is there any mobility taking place in the area of the wound that may delay wound healing? Are the sutures intact, or are they too tight? That's another issue that we must look at. So meticulous cleaning and then dressing of the wound. So various antiseptic solutions can be used: povidone, Savlon, iodine. Hydrogen peroxide, usually for infected wound. This is essential, especially for wounds that are infected with a certain genus of microorganisms called Clostridium. Clostridium tetani, Clostridium perfringens, Clostridium botulinum, such kind of microorganisms that survive in anaerobic environment can be treated with hydrogen peroxide or fumigation with oxygen. If there are any drainage tubes available or inserted in the patient near or at the wound site, we must make sure that they are patent and we observe the drainage from those tubes. Advise the patient not to pull them because, of course, they're uncomfortable. Some patients may want to remove them. You're just recovering from anesthesia and maybe proper education was not done prior to the operation. You find that this patient may try to remove them and cause injury to themselves. Equally, they must be able to know that this drainage is not running. You must educate them and make sure that those drainages are kept patent. Medication is important, and I can't overemphasize this one. We are starting with infection prevention. There's a wound which is exposing internal environment to the external environment. So we want to prevent infection. So prophylaxis is given. Various antibiotics are used. In this case, we're talking about ampicillin. Drugs can be used also to control or manage pain. So we have narcotic analgesics and non-narcotic analgesics. Things like pethidine, morphine. Those are narcotic. Diclofenac, paracetamol, ibuprofen, aspirin. Those are non-narcotic analgesics. So for severe pain, we are going to use narcotic ones, pethidine mostly. Then fluids also can act as medication. Oxygen, that's medication. Okay. So some of these drugs will be given together with intravenous fluids. They will run at the same time. Other drugs that can be given, you find this patient can be given some, anti-inflammatory drugs that may limit production of secretion. For example, atropine. It's very effective in reducing exudate formation, which is a resultant effect of inflammation caused by surgical incisions. Of course, I've talked about this. You can look at hygiene. Of course, we say the environment should be clean, but our patient should also be clean. So make sure the wound or incision site is clean, patient is kept clean. A bed bath or assisted bath can be done, can also help the patient with other activities of daily living, oral care, hair care, perineal care, in an event that the patient cannot do that on their own. Psychological support, this is important during post-operative care. Fears set in because of maybe stereotypes, things that patients have heard before. If you remove gallstones, most patients die. So patient may be wondering, am I also going to be one of those that are going to pass away following this operation? Operations to do with reproductive area, they might have heard, after this operation, you lose fertility. Such issues may concern patients. We must be able to address them, allow the patient to create an environment where the patient, they are free to ask and air out their concerns and address them accordingly, because you have the knowledge of that particular procedure and condition that the patient has and its outcomes. Of course, bearing in mind that you don't have to lie and don't have to alarm the situation to the point where this patient becomes more anxious now. Exercise, you promote or encourage exercise where necessary. So two types. We can do passive exercises and active. Passive, you are helping the patient to do exercises. These are essential because if a patient stays or remains confined in bed for too long, other complications might come in due to stasis of blood, for example, deep vein, thrombosis, ulcerations, bed sores. So such kind of issues must be able to look into and exercise the patient, especially prevention of deep vein thrombosis, exercising of the lower limbs. This is where we do also coughing exercises. Most importantly, in patients who have undergone thoracic, procedures to do the chest, pneumonectomy, lobectomy, such kind of things. Patients may require serious deep breathing exercises, usually by the use of a balloon. Patient is asked to inflate a balloon, maybe over a period of 15 minutes. Inflates the balloon, deflates it, inflates again. As they are pushing air in the balloon, that is encouraging or promoting lung expansion and also removal of any possible secretions that may accumulate in the airway. That is very important. Elimination, all human beings excrete. It is part of normal physiology. And if there's any interference with excretion or elimination, then disease may set in. Fecal matter not expelled, urine not expelled, blood becomes toxic, and that may lead to other complications. So you monitor output. Of course, urine, you're also monitoring bowel movement. How many times is the patient opening bowels? How many times the patient passing urine? What's the color of this urine? Are there any abnormalities? You do urine analysis, stool examination to detect any abnormalities. Could be bleeding. You see blood in stool. Is the patient having painful defecation? What's causing that? Must interest you. When you're done with all these interventions, there must be some education that must take place. What should you teach the patient? Most importantly, the patient should know when to come back. So what are the possible complications that this condition may produce? Or what are the possible complications that may follow after such kind of a particular operation? Some complications may occur in weeks, months after an operation. In addition to that, medication is very important. Strict adherence. How often should you take this medication and for how long? Wound care. Patient goes back home with wounds. How do they maintain clean wounds? Teach them while they are in the hospital how to clean. Don't assume that they will know. You know because you have been trained, but they're not trained like us. So we make sure that you teach and check if at all they've understood and know what to do, how to keep that wound clean, dry, and free from infection. Diet. Emphasize on which kind of food will promote healing, which kind of food will give energy, and of course fiber for prevention of constipation, because of movement is affected, especially those that may have fractures, dislocations, and what have you. Constipation may set in. Sometimes it's drugs that the patient is taking that may cause constipation. So one of the major treatment is fluid intake. Increase fluid intake and high fiber diet. Cereals, maize, rice, bran, such kind of things will give high fiber to the patient. Of course, postoperatively, the various complications that may occur, you may need to teach the patient. You have to observe if at all any of them are developing while the patient is under your care. Infection. Pus on the wound. Wound that are reddish, they're not changing. Wound is supposed to be covering, closing. You find the swelling. Next thing you see is pus. That is infected wounds. Poor management of the patient there. Management is both ourselves and the patient. We must teach them how to prevent such. Sometimes it's wound separation dehiscence, gapping, sutures coming off. We must teach the patient, especially if they have operations to do with the abdomen, operation to do with the chest, operation to do with the pelvis. When the patient are coughing, which is a normal reflex in the human body, they must guard the wound to avoid separation. So they must support and prevent wound dehiscence or rupture where sutures come off, and that can cause serious bleeding if it happens at home. This is what I'm talking about, dehiscence, evisceration. Contents of the internal organs protruding to the external environment. An intestine, it could be any part of the human body there that can come out. Look at the sutures there. sutures have come off, and shock due to bleeding or may arise due to infection or anesthesia. Patient is reacting to drugs. Patients may have keloids. These are scars that are overgrown. There's oversynthesis of collagen. In some individuals, fibroblasts misbehave, and you see, sometimes it's in the ear there, on the ear, overgrows because of overactivity of the fibroblasts. There are quite various, so many complications. Patient may develop pneumonia from aspiration or from inactivity, lack of deep breathing exercises, secretions accumulate in the airway, infection sets in, patient has pneumonia. Microorganisms love environments where there is wet, is enough temperature, oxygen, depending on the type of microorganism, and available nutrients. Otherwise, this is the care given to the patient post-operatively. Otherwise, we'll have a discussion now on other parts of surgery.